All right. Wonderful. So you guys can hear me okay. Good morning, or I guess I should say good afternoon. So thank you again for having me. I'm excited to talk about this topic. We had a similar session at the ACCP meeting this past year. Familiar with Zoom? If you want to use the chat, I can go ahead and monitor that throughout today. I have a couple different questions throughout today's material if you want to type in the chat. But I would also love it if anyone is brave enough. I have some open-ended questions throughout our slide deck today for some participation if you want to maybe share your practice model or maybe one that you've come across as well. All right. To gear my questions to these. So we're going to talk about some changes, some recent, I have some legislative slides toward New York is definitely a little bit different than Virginia, and there's some differences across the state. So I'll try to point out some of those differences. I'll talk about some of our practice innovations and others I've come across. And then finally, where pharmacists sort of fit into all this. And I'll give you some examples of how we've been doing things. And so here's the specific learning objective. So I'm going to talk about different models, treatment-based models for opioid use disorder. We'll talk about some best practices. And then finally, towards the end, what are some of the barriers? Why haven't we gotten further than where we are today in terms of pharmacy services in managing not even opioid use disorder, but really substance use disorder? Okay, so I have one patient case. This one patient we're going to kind of follow throughout for the next 50, 45 minutes or so. So very typical patient we would see in our clinic, a 34-year-old male that is establishing in our primary care clinic today. He needs a return to work physical for his new job. Doesn't really take anything, no past medical history. There's his vitals. We get a routine urine drug screen in the office. His work required that on the physical, and it's positive for cocaine, oxycodone, and morphine on the instant. So when asked about the results, the patient expresses he wants to get off medications, doesn't want to be using these drugs anymore, so he can hold a steadier job. Okay, so we're starting with a simple question. So use the chat. I think that would be easier than everyone just shouting out letters. So what do we think is the best option right now for MK? Should we send him to the emergency department? Should we tell him to just cold turkey stop things as of today? Should we refer him to psych? Does he need to go to an outpatient treatment facility and maybe start meds if indicated? And then finally, we need to admit him. He meets criteria for admission because of the cocaine. So what do you guys think? Or nobody knows? Ooh, a D. Thank you. Yes, I like D too. I like D too. So D is really what we would do right now. I think he doesn't really meet criteria for admission. And that's different than, say, if this patient had presented, say, 20 years ago, right? If he had presented 20 years ago with that urine drug screen saying he wanted to come off of opioids, it's very possible that he would have been sent to the emergency department, especially if there wasn't an addiction program readily available. I'll go back to some of the other choices. You know, psychiatry for the most part is not where we're sending patients like MK now. He might need a psychiatry referral depending on further workup and if he meets criteria for other things. But here at our clinic, the wait list to see a psychiatrist is much, much longer than to get into our addiction program. So that might be a referral down the road, but we don't necessarily need to get a psychiatric diagnosis. Cold turkey is possible and well within his rights to do, but it's probably going to be pretty uncomfortable. And for the most part, we have medications to make MK be more successful. We also have support systems and channels, which we'll talk about if he decides not to use medication to help support him further. So D is the best answer here. Okay. And so that's changed a lot over the course of the past 20 years. And next, I'm going to talk about some different treatment-based models. So what are we currently doing to help patients like MK? Okay, so very busy infographic, and this is a great reference. I think, Sydney, if I can share my slides with everybody, I'm happy to do that so they can have some of these references. So this is a great paper, the Alliance for Addiction Payment Reform, published in 2023. And so this was an infographic from the paper that was really exciting because if you notice, they include pharmacists as part of the addiction care recovery team. And there's also a whole section in the paper talking about the role of the pharmacist, right? And so as you can see, at the center of this is some type of coordinator. So this is going to vary depending on the program. But there is a role for primary care. There's a role for counseling, potentially a role for behavioral health, some coaching, group work, if they need social services, other community support, and then maybe even physical or dental specialists, depending on their current medical needs. And then clinical pharmacists had a whole spout carved out in and of itself in this publication from 2023. So within this recent publication, they talked about a addiction recovery medical home model. And this is one of the basis of the practice that I'm at, and we'll talk more about into my specifics, but the whole goal of this model, or ARMH, is to organize treatment for patients that have substance use disorder. The patient is at the center, and we manage these chronic disease states to overall improve patient outcomes. There are 5 different elements to an ARMH. The network itself, the metrics that we're meeting, we'll talk more about metrics in a minute, the whole care recovery team, model. How are all these different entities and folks going to be reimbursed for these services? And then in that third bullet point there, you can see the different networks that are involved in this model. Depending on the patient's needs, it could be inpatient, it could be outpatient. There needs to be some support for integration between these different healthcare entities. So a patient like MK, if he gets started in an outpatient treatment facility, and then he's potentially going to a social worker or getting counseling somewhere. He might also be getting primary care at a different place, psychiatric services at a different place. So and then if he gets admitted or there's some type of change in where he's receiving care, inpatient admission, outpatient, long care, there's a lot of different transitions of care to get all those different networks to talk and communicate each other to ultimately support MK in his recovery. So it's super exciting to see us called out in this addiction model and essentially moving towards we'll talk about a value-based care model and reimbursing healthcare providers for doing this work. So what's the role of the pharmacist for a patient that has some type of substance use disorder? So this slide is probably pretty barren. I could probably add a lot of other things that I do for our patient population or that some of you might do as we could brainstorm and think about the list. So I put some of the most obvious ones that I really started when I started at the Saratoga Community Health Center. But again, overall goal is to improve patient access and improve care. Initially, one of the things we're involved in is creating the initial treatment plan. So given the patient's history, medications they've tried and failed, also their insurance, what will be covered for the patient, what's a good long-term plan, we can come up with a treatment plan. We also will support the first 72 hours to 7 days, and if they have any withdrawal symptoms and managing that, collaborating with other healthcare professionals. So my site is also integrated within primary care. We have psychiatry services as well. So sometimes we need all 3 of those folks to talk, to coordinate care and the medications that we're using. A big part of our job is longitudinally following patients to monitor and assess the regimen. Are they stable? Are they having any side effects? Are they having any medication access issues? That's a big one that we help with. And really just overall comprehensive med management as things get stopped and started to optimally provide the best care for the patient. Okay, So again, I want to send these slides so you have a copy. These are a ton of different references that reference the hub and spoke model. So these are some of my favorite initial references. The Vermont one we're going to talk about the most, but this is a pretty common model to provide substance use disorder, either in a primary care setting or not. It could also be used in specialty. It really first started in Vermont. Other states have adapted it, have changed it, have done it a little differently. Vermont might have its own, not sure. But what's interesting about the hub and spoke model is this was also really started. Couldn't have one prescriber writing 500 prescriptions of buprenorphine, right? We had to limit it. So this hub and spoke model sort of started, but it also really gets to the coordination of care, that these patients have a lot of social determinants of health. It's not easy to just give them a prescription, send them on their way, think they're going to be successful if you see them every 3 months, right? So there's a lot of other inner workings and pieces to the hub and spoke model. So let's dive into hub and spoke. So the Vermont example, like I said, was one of the earlier ones. The hub, if you can think it as the center of a wheel, and the spokes are the different spokes out, are the folks that are also touching the patient and involved in improving primary care. So kind of like that graphic that I showed you from the Alliance for Addiction Payment Reform paper, very similar. The hub is maybe the initial assessment, the first time the patient presents when you do an intake. The care coordinator could do that. Maybe that's in the Vermont example. Maybe that's when you first initiate methadone, or could also be bupe, depending on the treatment facility you're at. Or it could be the initial consult, the referral from a provider saying this patient's interested in getting treatment for substance use disorder. So what are some examples of the different spokes that come out of the hub? Again, there's a lot of examples. These are some of the more common ones. The spoke could be maybe the counselor, the social worker, whoever their sponsor is that's working with that particular prescriber. But not always, right? But that could be potentially a spoke. A lot of this is social determinants of health, different family services. Our spoke example are legal counseling. If patients are, involved in parole or involved in family court, some type of legal counseling is an important spoke. Mental health services, so psychiatry can also be involved. Maybe a therapist that they're seeing. Housing, right? So residential services, so having someone that's helping with stable housing. Inpatient, outpatient treatment plan, right? If they're an intensive outpatient, maybe they're still inpatient, there's a plan for discharge, if they're going back and forth. And then sometimes patients can be outpatient and stable, but they have to go inpatient for something else, completely unrelated to their substance use disorder. So that's also an important spoke. The medical home we talked a little bit about, if that's available to you. And then finally, pain management can become really important. So this is a big part where I fit in as a pharmacist, as part of the hub and spoke model at my site, is patients that are on medications like methadone or buprenorphine, naltrexone for substance use disorder, and they have chronic pain, or they have pain management needs for a procedure that's coming or a procedure that they just had. How do we best manage that pain on top of the medications that they're currently on? So some other models besides the hub and spoke, there's some other that are published in the literature. The ASSERT model, the bridge model, and the ED bridge model. So bridge and ED bridge are really focused on having someone in the emergency department. So oftentimes patients that are either interested in substance use disorder or actively abusing substances, that's where they might present if it's the most accessible. They might not know a clinic that they can come to or an outpatient program, if they don't have a methadone program that they can go to and get started. The ASSERT program starts more with having someone in the community, a support staff worker, a community health worker, someone that has tied to the community, that knows about those resources I just mentioned, that knows, hey, if you want to get help, if you want to get off of these substances, here's where you can go into a local treatment program more successfully. Whereas the bridge and the ED bridge really have a prescriber that are in the emergency department, and then they also have relationships to those different resources. Okay, so quick knowledge check question about the really 4 different models we just went over. So which of the following statements is true regarding the hub and spoke model for opioid use disorder? Let's try to use the chat again. Maybe I'll get more than one response. C, awesome. Thank you. So yeah, spokes do not have to be medical providers, right? So I just mentioned all the different spokes and different examples of spokes you can have. A spoke could be a community health worker. It could be an insurance company. It could be someone helping with housing, legal services, right? A hub is not necessarily where the patient's housed. The hub is typically where the initial consult is started, the intake is started, and the hub is typically the prescriber that's doing the medication if they're on medication. C is the right answer. Absolutely, the goal is health integration. And the model can certainly be used in every state. I only gave you a couple state examples just based on the recent publications. But New York wasn't listed, and that this is certainly a model that we follow. So it certainly can be done with maybe some tweaks and variations depending on your resources. Good. Okay. So I wanted to talk a little bit about our program and how we provide care to patients with substance use disorder at the Saratoga Hospital Community Health Center. So I'm in upstate New York, in Saratoga Springs. If you fly into Albany, it's about 40 minutes north. And we are an OASIS accredited addiction program. So OASIS is essentially, I always get this wrong, the Office of Addiction and Substance Abuse Services, I believe is the right acronym. So we're accredited by New York State. We have on-site 2, sometimes 3 CASACs, which are credentialed alcohol substance abuse counselors. Those are also specific to New York State for the most part, but they are social workers that are specialized in different drugs of abuse. We have inpatient and outpatient services. And what's unique about our hub and spoke to primary care is our addiction provider that I work with spends some time inpatient and in the ER. He will also take consults from inpatient in the ER for patients that are interested in starting medications for MAT, medication assisted treatment for whatever addiction they have, and then coming to our clinic and seeing us as follow-up. So we start as the hub, either my addiction provider or one of our CASACs. They'll do the initial intake, start medication if it's indicated, and then once the patient is stable, they can then be spoked out to primary care. And so that's a term that we use a little bit different. Like I mentioned, the model that we showed differently, but if a patient is stable on maybe MAT, or if they're not on medication and they're stable in their recovery, we might send them back to primary care to continue their general health and wellness. The CASAC can continue to see the patient outside of being seen by our addiction provider. So we do have that. But our medical group has over 20 primary care and specialty practices. We're a multidisciplinary group. So outside of primary care and addiction, we also have other disciplines and specialty offices that we can refer patients to. We have a methadone clinic in Albany, but we're only doing buprenorphine and obviously naltrexone at our office. But for the most part, patients travel far to see us. I mean, we do have a lot of patients that are local in the area, but we have a great interdisciplinary team. We do virtual visits, so some telemedicine too is also an option if patients have access. And then the hospital we have direct access to for inpatient and outpatient as well. So what's interesting about how I got involved was in 2018. Someone at the Saratoga Community Health Center wrote a grant for New York State to have us do better on our opioid stewardship. And part of that grant was to hire a pharmacist. So I'm a faculty member at Albany College of Pharmacy, but I saw the job posting and I was like, oh, I would love to be a part of that work. And so my practice site is at the Saratoga Community Health Center, but they also hired a full-time pharmacist that does a lot of this work with me, managing addiction patients, managing pain patients throughout the medical group as part of an interdisciplinary team. So it was a 2-year grant, but the medical group felt that it was an important service. The providers liked it. We demonstrated a great need. Not a financial benefit, we'll talk about the billing in a second, but honestly, just providers' time, improving patient care that the medical group justified continuing to pay for the other pharmacist's salary. Okay, so I would love to hear if there's anyone that has an addiction care model that they're working on. If not, it's fine. And I know it's a little bit of a small group and there's some students too. But if you have maybe students that have rotated through an addiction care model where a pharmacist is working, or if you know of one, if anyone wants to share, I would love to hear, because my model is definitely not the only one. Does anybody else have a addiction care model with a pharmacist involved? If not, that's fine too. We can keep going. So maybe that's a need. Maybe that's an area where you guys can expand. All right, let's get back to our patient. So he meets with one of our CASACs. So what's kind of great about us all being in one building, if primary care identifies a patient, we can actually do a warm handoff, have the patient go meet with the CASAC right then and there when they're ready to start treatment. If that's not an option, we do have walk-in hours at our clinic. They can come back for walk-in hours or we can schedule an appointment. So trying to be as accessible as possible. The CASAC, so that's a credentialed alcohol substance abuse counsel, will do the initial intake and screening to make sure they are appropriate for our program. And the provider, our prescriber that does the buprenorphine, he's the director of our addiction program, will provide a 5 to 7 day prescription depending on the substance and the need and that initial intake. And then the patient could also be provided with some other medications to help with the withdrawal they might feel. So clonidine, gabapentin, others as needed. We usually instruct patients to call us if they have any other symptoms so we can provide loperamide, what have you. We do provide every patient with a Narcan kit to take home. So myself or my pharmacy students will oftentimes do a training. We're a certified Narcan center, so patients or even family members, healthcare provider, anybody can come to our clinic and get a free Narcan kit that New York State pays for. So we'll provide him with a Narcan kit. We'll do an initial COWS assessment. He usually will get one done too over the phone within 72 hours. And then when he comes back within a week, we'll do another one. He usually will follow up within a week with the prescriber, depending on scheduling and availability. And then he'll follow up with the CASAC at least every week, if not every other week. And the CASACs and the prescribers are in, they consult each other a lot in terms of continuing medicines, stopping medicines. They'll consult me if there's side effects or things we're dealing with, drug interactions. And then we do a urine drug screen at every appointment. So this is kind of how we would get MK started up in our clinic. So let's talk a little bit about what works and what doesn't work. There's a lot of different models for substance use disorder treatment. There's more of a harm reduction approach. There's more of a strict, our way or the highway approach. And so this is just some things I observed in doing this for the past 6 or 7 years. What is helpful is an outpatient induction, right? So if it's safe and the patient is a good candidate, not having them go to the emergency room in the hospital, we can do all of this outpatient now. Having the CASACs or some type of social worker that has training in substance use disorder is super helpful. To have them engaged, to have them working with the patient, doing counseling and working through things. They can also typically meet with the patient more frequently than, say, the prescriber can. Close monitoring and flexible treatment options, right? So using different pharmacotherapeutics, if it's buprenorphine, naltrexone, no medication at all, long-acting injectables once they're stable. So all those things are helpful. What's not helpful is if the patient doesn't come a lot, right? So poor compliance, no-shows, resistance to the program structure, right? So they only want to see the prescriber, but not the CASAC. Requiring a psychiatry for referral or requiring a psychiatric eval, that oftentimes is a barrier and a holdup to care. That's a huge role that I sometimes will play if the patient has real medication needs for psychiatry, and we can't get them into a psychiatrist. We'll start the buprenorphine prescriber will actually start some meds for psychiatry, and we'll talk about different options. We also do pharmacogenomic testing at my clinic. I'm happy to talk about that. I love pharmacogenomics to help try to streamline what medications we're starting. And then insurance barriers are the bane of my existence. They do not help at all. We have a lot of issues in New York of, yes, something is covered, but they will change it on a monthly basis. Prior authorizations can delay the amount of days they're allowed in between visits can also be a problem. And then for some of our patients that are on prolonged injections, when they really hold you to the day for some of these, it can be difficult if it falls on a weekend or there's a conflict and they can't come into the office. So insurance barriers are really an issue for these patients that pharmacists essentially help navigate all of these. Okay, so I want to talk a little bit about billing and fee for service type things. So within the past year or so, I mentioned we started with a grant and it was great. And then after 2 years, my partner, it was kind of like, well, how are we going to continue to justify his salary, right? Because we're not really billing for a lot of these services. So after doing some digging, one of the codes that he's primarily using, and myself as well, is this 99484 code, Behavioral Health Integration Service. So this is a fee-for-service value-based payment where essentially, because these patients are also being seen by primary care for the most part with us, we're coordinating across different treatments, different healthcare teams. We can bill this code, and our CASACs, our providers, are billing a different code for the initial treatment. That's the 99492 code. The subsequent collaborative care management visit is the 99493. And then these subsequent visits, 30 minutes per month, is where we can essentially come in and drop a bill, even if they're seeing other providers. So a good example, let's use MK as an example. He's established in our program. He's being seen by, he has a case manager that's helping him. He's going to therapy every other week. And then they want me to meet with him to go over a side effect that he's having, right? So I can also bill a 99484 code in addition to maybe his care manager that called him on the phone and spoke for 10 minutes. I can then bill for the 20 minutes, the remaining 30 minutes in the month. So we actually built a template to do this. I have that pulls into our Epic template when the last bill was dropped for the patient, so we're not overbilling. And as long as they are being involved in these healthcare manager activities, we can drop this code, and we've gotten pretty decent reimbursement as far as a pharmacy service goes to help manage these patients. You know, it doesn't necessarily have to be side effects. We've done it for urine drug screen interpretation. I mentioned pharmacogenomics. We've done it to make a pain management plan around a procedure that they're having or a procedure that they just had. So anything as it relates to the patients being successful in their recovery. 99484 is the code we're using. Here's some kind of stipulations, and this is straight from the AAFP, and this is what I use, and hopefully we're doing it right, but you do have to have a continuous relationship, right? So if the patient isn't seeing their prescriber anymore, or they haven't really engaged in it with the CASAC anymore, they're kind of falling off. If we don't have a continuous relationship, I wouldn't use this code. It's coordination of behavioral health, right? So if I'm helping with diabetes, if I'm helping with blood pressure, I wouldn't use this code. This is more specific to their substance use disorder, or if we're doing behavioral health consultation as well. They don't have, the person doing it, so me and the other pharmacists don't have to have any additional training, education, anything like that. Patient has to be seen within a year. That's typically not a problem in our program. They have pretty close follow-up. And the patient does have to consent. So we had this built into our Epic consent when they consent for treatment, when they come initially to present, and when they do that initial intake paperwork. So there does have to be, ours is written where they sign consent that's documented in the medical record. So those are some stipulations around billing that 99484 code. Okay. Any questions about 99484 before I talk about what value-based care looks like for opioid use disorder? We're doing good on time. Okay. No questions. You guys are all still with me, or everyone's like, I don't know what she's talking about. All right, let's talk about value-based care. So again, all great things in terms of pharmacists being involved in substance use disorder. So there was a program that was started in 2021. And so this was value-based care, basically saying Medicare, we want to show that there is benefit to doing a value-based care model. So what is the benefit of kind of lumping all of these services into one on patient outcomes, of cost, you know, overall, what does this look like if we make opioid use disorder a value-based care? Oh, I see a question. Have you considered DM distress as it means to bill for DM visits under this process? Oh, like their diabetes is not poorly controlled? Is that your question, Nicholas, maybe? Their
No,
diabetes.
sorry. The psychological state, diabetes distress. Are you familiar with that?
I am not.
Um, okay, yeah, I was just curious. I work closely with an endocrinologist who has
Yeah.
presented on that state, so just wondering if it was potentially related to the behavioral health component.
Yeah, no, that's really interesting. I mean, we do a lot of billing for diabetes. There's like way more codes my team uses for diabetes. So interesting to know that I'll have to look at that. Thank you. Awesome. All right, let's go to my next slide about value-based care. Okay, so the call was put out in 2021. They reported out in 2022. This is still ongoing. We're not done yet, but I feel like this was pretty obvious, right? Doing a per beneficiary per month care management fee, they enrolled almost 1,000 patients, 943 patients. When they lumped a lot of these substance use disorder patients into this group, they found fewer hospitalizations, fewer emergency room visits. It also lowered the overall Medicare expenditure. So it was less to be paid out for the plan, about 15% less. And they also looked at hepatitis C costs because there's a higher incidence in this population, but there was no difference here. So one of the things about this initial report that came out is what would these incentives look like? So one of the biggest things that's debated for the addiction providers that I work with is what does treatment success look like for this patient population, right? So value-based care for diabetes, if your A1C is 7 or lower, awesome. You're winning at diabetes, right? And so that's easier to give a bonus, to give a reward, to give some type of monetary for value-based care if someone's diabetes is at goal. We have a clear goal. But what does that consensus treatment success look like for someone that has substance use disorder? Is it that they come to their appointments? Is it that their urine drug screens are appropriate? Is it that they graduate off of whatever substance they're using, if they're on bup or methadone or naltrexone, and now they're on nothing? So there's not a clear consensus of what treatment success looks like. Um, there's also a lot of care coordination for this specific patient population, access challenges, communication barriers. I talked a lot about these already that might not necessarily be as prevalent in, say, the diabetes population, right? So the housing, marital family issues, legal issues, incarcerations, a lot of those things that are unique to this patient population that needs to be considered if we're going to move to value-based care. One of the other things is these services are chronically underfunded and understaffed. So we're constantly talking about in New York, there are not enough KSACs graduating to go around and meet the need in our state. And the other thing about this value-based care model, in the first two initial publications, pharmacists are not mentioned yet. So I potentially, or based on what I've presented so far, hopefully you can see that there's a need and a role for pharmacists in this patient population. So back to MK. So we got him started on 8 milligrams a day of bup. He takes it twice a day, so he's on 16 milligram. His cow stores are stable. He sees his KSAC every other week. He wants to potentially think about transitioning to the injection, so maybe the Sublocade injection, buprenorphine injection for ease with his new job, so he doesn't have to come as often. And his past 3 months of urine drug screens have been clean. So knowledge check number 3. So what do we feel like is the role for the pharmacist with MK? We'll use the chat again. Do you think it's urine drug screen, transitioning from oral to injection? Do we want to provide education to the patient, or do we want to train our nursing staff? Or do we want to do all those things? What do you guys think? E, yes, all of the above, right? We want to do all of these things. So a lot of these things I've already talked about. just because his urine drug screens are clean, is that appropriate? Do we expect to see something in there? So we would assist with that. Um, Transitioning from oral to injectable is certainly something that we will help the prescriber with. The first thing about that is I usually have to get on the phone with the insurance company, figure out what's covered, if a PA is required. We also work with a specialty pharmacy that will direct ship the product to our clinic. So we work closely with them. They oftentimes help with the insurance issues as well. Education on buprenorphine injection and adverse effects. If this is going to be a new medicine to him, we'll talk about the whole process. And I've trained all of the nurses on how to give the drug. It's kind of an interesting reconstitution process as well. So we walk through that, make sure they know how to give it properly. The students and the residents like to watch the reconstitution and see how it's been given. So all of these things we would play a role with. Are there any eligible Medicare, Medicaid beneficiaries in the study? Curious if the outcomes vary for dual eligible versus Medicaid only, or if anyone is studying the treatment model for Medicaid. Great question. So that 2022 publication was just the initial report out. The whole thing is due, I believe, in 2026. And I would think there are probably some dual beneficiaries in the study. We certainly have dual beneficiaries in our population, but that is a great thing to look at to see if there is a difference. Great thought. Okay. So we get sent MK to be seen by the clinical pharmacy team. We're going to review his medications, the dosings, the side effects, ensure adequate drug delivery. And then the biggest thing we'll start is education around the injection. I mentioned our process with his insurance. We'll reach out to our specialty pharmacy colleagues and what that looks like, making sure we get the shipment appropriately. Once we have confirmation for payment, we'll set up that injection appointment with our nurse. And then sometimes we'll do visits same day. So they'll meet with me or one of my residents or team first and then get their injection done. And then we'll do a follow-up, especially after their first injection, to make sure that they're, tolerating it appropriately. Okay. So here's some alternative scenarios. So other things where my team, I was just thinking over the past month or so, when I was putting these slides together. So questions that I've been asked. Here's a couple. He's got a scheduled tooth to be pulled, and the dentist reaches out to me and asks about pain, or the patient is concerned about pain after the procedure. A common one that we'll get when patients get up to higher doses of buprenorphine is they are constantly having a headache after they take their dose. And how do we manage that? The patient's insurance either changes or the insurance doesn't change, but the formulation of buprenorphine that they cover does. So there's a lot of different branded generics, and some of them are preferred over others. And this can change, unfortunately, on a monthly basis. So sometimes we have to navigate that process. What if his urine drug screen comes positive for something like cannabis, right? And other different aspects or various social determinants of health that could impact his overall patient care. So all of these would be a reason for us to meet with the patient, consult. Sometimes we'll meet in the same visit with the KSAC or with the provider and drop that behavioral health care management code. Okay, so in the last 10 minutes or so, I want to talk about barriers to pharmacists doing this work. Why aren't there more of us doing this work, and how we can hopefully expand. So the obvious big elephant in the room is just the recognition as pharmacists as being a valued member of the healthcare team. And so I took that language from ACCP. So instead of provider status, it's not really provider status anymore. It's just being recognized for our services and reimbursed for our services. So there's a handful of states where pharmacists can prescribe controlled substances. So I looked when I made these slides, and I don't believe Virginia you can, but someone correct me if I'm wrong. So these are the states that you can prescribe controlled substances. I did my one year of my residencies was in a VA, and so a pharmacist that was licensed in California could actually write for controlled substances at any VA. But in New York, we can't prescribe controlled substances. I don't believe you can in Virginia. So this is potentially a barrier to, if pharmacists were going to get involved in helping with substance use disorder, particularly opioids, and being able to prescribe something like buprenorphine, right? Because it is a controlled substance. Collaborative Practice Agreement, or CPA. So I did look up in Virginia, your guys' CPA legislation is much better than ours in New York. So the specific one that I read was really structured towards your payers. So your payers are being directed to reimburse for your services. And so that was fantastic. And maybe you guys could give me some examples of how that's going. In New York, one of the issues with our CPA, it's very new. A collaborative practice agreement has to be signed between the physician and a credentialed CPA pharmacist. The credentialing goes through the New York State Pharmacist Department. You basically get a letter after your name. There's certain things that you have to have that credentialing. But then essentially you can, for a specific disease state, you can adjust medications. You can't start anything, but you can increase, decrease, monitor, and then recommend discontinuation. So it's very specific on what we can do within a CPA. And one of the biggest problems in my state is that the payers do not adequately recognize a pharmacist as being a credentialed provider. So if we send a prescription to a pharmacy, we usually get a rejection back from the insurance payer saying that that provider is not recognized, even if you have an MPI number and you're registered and everything. So it's a constant battle we're fighting in New York, and it varies from state to state. But it did seem like Virginia, you guys had a much better leg in terms of the providers. So if anyone is actively getting reimbursed in the area of substance use disorder, I would love to know about it. Maybe we could chat offline, or if you have an advanced practice model where you're getting reimbursed from these services, or even if the pharmacy is recognizing your prescriptions, I would love to know about that as well. Okay, so one of the things I hear a lot, particularly in this space, is that do pharmacists have the training? Are we adequately prepared to provide substance use disorder treatment for patients? Can pharmacists do this? So this slide, I believe there might be a couple residencies that are in pre-candidate status, but what's interesting is how much this has grown in the past 10 years or so. So 30 accredited pain and palliative care PGY2s, 77 accredited, that should be psychiatric care PGY2s. I think that error didn't get copied over. Pain and palliative care have 30, and these are accredited. There's probably some in pre-candidate status. 77 psychiatric. There is board certification for pharmacists in ambulatory care, psychiatry, and the pain management exam is going to be live, and the first offering is probably going to be fall of this year. So we have second year residency training, we have board certification. Substance use disorder falls in really all of those, AmCare, psychiatry, and pain management. So what's important to recognize here is that we have, if a pharmacist is interested, different training avenues to get that additional either residency or board certification. And a lot of states have also had enacted legislation around pharmacists being able to give long-acting injectables. That was something that just got passed last year in New York. We're usually one of the last to do it, so you guys might have had it for a while. So pharmacists in the community being able to give that Sublocade injection, or potentially if you're doing Vivitrol, so the patient doesn't have to go back and have another step to go back to their office to get that done. Another argument I hear is that we don't have the time. Pharmacists are being asked to do more and more and more. These patients, if you've interacted with patients that have substance use disorder, chronic pain, they do take a lot of time, right? This isn't a 10-minute, 15-minute visit. My visits are usually 30 minutes to an hour. But this is an awesome area for job growth, for expansion, right? I just gave you one example of the code we're using for reimbursement, but if the value-based care takes off, if we follow a lot of what was published in that Addiction Alliance reform, this could be an opportunity for additional positions to be created. We're just one example of using a grant as a springboard, but this can really be an area for further recognition of our clinical value. So I think I've convinced you of a lot of other these things as pharmacists being considered a spoke provider. We're following collaborative care, collaborative practice agreements for a lot of other disease states. It's been demonstrated with blood pressure, diabetes, so why not opioid use disorder? And some pharmacists are already doing this work. And here's a couple examples of publications that are working with a prescriber, to expand this patient access and to help really just get care out to those who need it. All right, so let's wrap up our patient. So we've now switched him over to buprenorphine injections. He sees the prescriber every 6 to 8 weeks or so, and he sees his KSAC monthly. He's had 1 urine drug screen that was positive for cocaine and marijuana, so he's doing pretty good. But now he wants to know, well, how long am I on this injection for? Right? Do I have to be on this forever? Can I taper off of it? He's curious about, he has an ACL repair coming up. What's pain management look like for that? So again, just multiple examples of how a clinical pharmacist could get involved in providing care for MK and, potentially not only showing value, but having an option for bringing in some revenue as well. So my last couple slides, I just wanted to review some legislative updates. This first slide is probably the most exciting. So this was a bill that was introduced last session called the Support RX, the Substance Use Prevention and Pharmacy Oriented Recovery Treatment Prescription Act, Support RX for short, that came forward from Senator Cory Booker, but it has Republican and Democratic support. And what's really exciting about this bill is it wants to provide demonstration grants, so similar to that value-based care model, for pharmacist-based addiction care programs. So they want to look at pharmacists doing these addiction services and what the outcomes look like. And this is really this is a federal bill, right? So this isn't state specific. This would be awesome to have federal recognition of collaborative practice agreements. This would be a great way to not only show our benefit to the patients, to the providers as well, but also that there's a value clinically in the services that we provide. It also calls out providing training, providing support for, the community, both providers, clinics, community pharmacists, and also for data sharing, right, in between all those different spokes that we talked about. So really exciting bill. I know a lot of the pharmacy organizations are behind this, so we'll see how this one pans out. So this one you guys are probably all familiar with. I just wanted to talk about it because the person that sponsored it is from my home state, Paul Tonko from New York. This became effective in 2023 to remove the requirements for buprenorphine prescribing. So again, pharmacists that are credentialed to prescribe controlled substances could then prescribe buprenorphine now that this is removed. And it removed a ton of barriers for patients that had issues with access for treatment for substance use disorder. And then this is our last legislation update. This is still on the Hill. They haven't had a ton of movement on this, but this is essentially to exempt buprenorphine from suspicious orders reporting system. So if you worked in maybe community pharmacy, hospital pharmacy, and I've also encountered this in my setting, one of the things is if your pharmacy orders too much of controlled substances, not just buprenorphine, any controlled substance, you can get flagged by the DEA. Right? You can get flagged. There's a limit to maybe how much you can order depending on your supplier. And so this legislation would remove that flagging, that warning from buprenorphine because we're using it for opioid use disorder treatment. And so pharmacies, distributors want to increase the amount of buprenorphine that's out there rather than decreasing it. And this would hopefully eliminate pharmacies from being out of stock, from having to wait to next month to order more, so they're not under that DEA scrutiny. Awesome. So this statement came out in 2024, last year. And one of the things I love about this is the American Society of Addiction Medicine, which is an organization I've been involved in. They have a pharmacist membership if anyone's interested. And they want more pharmacist involvement. They have a great push for interprofessionalism. They have this paper that came out that specifically calls out a strong role for clinical pharmacy in team-based opioid addiction. So the reference is here, but this is just one example of partnering with other, medical community, medical professionals and other professionals to help really combat this opioid epidemic to provide the best care. So I wanted to provide that statement as well. And our last knowledge check question, which of the following is an advantage of having an involvement in a clinical pharmacist in an opioid use disorder treatment? So what do you guys think? What would be an advantage? So hopefully everyone put B, right? So we're going to Increase patient access, improve patient engagement, that's the right answer. Decrease provider time with the patients because we're going to be following them more closely. And then we can improve interpretation of urine drug screens. Awesome. All right. So in summary, research has shown that, pharmacists can effectively engage and improve patient outcomes. There's a lot of different treatment models out there for opioid use disorder. It just depends on what fits for you, your clinic, your service, and your billing model. Obviously, reimbursement and payment is still a clear barrier, but there's calls, there's alliances, and there's work being done right now to show that this can be improved upon. And when it is improved, obviously we're going to need continued education and training programs to help answer that call. All right. And I think I saw somebody have a question in the chat. But that is the end of my presentation and slides. Thank you guys.